Good. Good evening, everyone. I'm Nico Enslin. I'm a neurosurgeon based in Cape Town at Red Cross Children's Hospital. And it's my great honor to welcome you all to this webinar that we're hosting on behalf of the SA-ChiLD Society. We're part of the Academy of Childhood Disability, an international group of people from various roles in the medical fields that have an specific interest in childhood disabilities and caring for children and their families with disabilities. It's a wonderful privilege for us. I'm so glad that President Ramaphosa blessed us by choosing our webinar day for a specific public holiday like today that we could all prepare for tonight. And I hope that all of you were able to go and do your democratic duty as well today. For those who will watch the video recording in future, it's voting day today, just before you start worrying that I've lost it or something. On the computer screen at the moment, you'll see the website for SA-ChiLD, and I'd love to invite you all to go and have a look at our website and to join the society. Please join. It's for a minimal a yearly fee, but it's really a growing society that we've established about 6 years ago. And slowly but surely we're making inroads, and our vision is really to reach all families and children with disabilities in Southern Africa and form part of a greater international community to support research and to support outreach towards families and children with a disability. I'm going to stop sharing this slide, and then I'd like to just introduce our three speakers. Today, our topic is we're looking at the finances of disability in a South African context, and I'd like to introduce our three wonderful speakers to us all. The first speaker is Maryke Bezuidenhout. Maryke is an old friend of mine. It was a classmate of mine. It's wonderful to catch up again in this format, Maryke, after it's 24 years almost now since we last saw each other. Maryke is a physiotherapist. She's an assistant director of rehabilitation and works at Manguzi Hospital in rural northern KwaZulu-Natal for more than 20 years. Here she gained an immense and deep grassroots knowledge and insight into challenges and providing rehabilitation services to people with disability, but that lives in proper resource constrained settings. It will be, Maryke will share some of her real life experiences with us, and she specifically look at this out-of-pocket expenses specifically that families has to incur when they have to bring their children to us for help and for all the rehabilitation services that it needs. Having a child with a disability is not cheap by anyone's standards. The second speaker will be Carla Brown. Mrs. Brown is the head social worker at Red Cross Children's Hospital here with us in Cape Town. And I've asked her to specifically speak about what the grant and funding opportunities is or options is for patients in the South African context for families and patients with disabilities. And then Mrs. Adelleen Gouws. Adelleen is a founding member of ACG Consult. She's an accredited tax practitioner, and her experience in this specific field of disability and related tax issues has proven invaluable in assisting clients with medical and disability tax claims in South Africa. She knows the medical schemes or the medical aid sort of side of things as well, and then specifically with her background as an accountant has a lot of insight that us mere mortals when it comes to finances definitely don't know about. And then we've asked Adelleen to speak about the tax implications and some advice for families and children of patients with disability as well. So on that note, I'd like to ask Maryke, if it's all right with you, please share your screen. And thank you again, everyone, for joining us. Welcome.
Okay, hello. Can you all see my screen?
There we go. We can hear you, and your screen is starting up.
Okay, so just as a disclaimer, I am a physiotherapist, not a health economist. So if there are health economists on this lecture call, please bear with me. I'm trying.
We can see your screen there. There we go. Thanks.
Fantastic. Whether it is going to transition, I'm not sure. It was transitioning just now. Let's try again. No.
Just try old school, sort of clicking on the screen with it. Sometimes Zoom doesn't work with the arrows or the mouse. Just see if you...
Here we go. Great.
Okay.
It's old school Zoom. Okay, so whilst the president has just signed the NHI bill into an act, and we are talking about universal health coverage, I thought I would focus on this. So universal health coverage states that people should be able to access healthcare of sufficient quality to be effective when and where they need without experiencing financial hardship. And that's a pretty big statement, and it's very difficult for even the best of countries to achieve. The key principles really focus on equity and coverage, so equity and access really, quality, and financial risk protection. If we think about our very diverse population, there are different socioeconomic statuses, there are different types of disability, different sexual orientations, ethnicities, cultures, literacy levels, legal statuses, languages, genders, ruralities, etc. There's never going to be one size fits all for service delivery. So we can't approach healthcare and health service delivery in the same way for everybody. If we do, people are going to get left behind. And it's those marginalized groups that are going to get left behind, such as especially children with disabilities, people with disabilities in general, and other vulnerable groups. But without data, they are going to get lost in the big mess of numbers. So we're not actually going to know that they've been left behind in itself. So we need to start monitoring them. So for those who are not familiar with the terms, financial risk protection is basically so that you don't become impoverished by trying to get healthcare. It can be measured in two different ways. Firstly, through catastrophic health expenditure. So this is whether your expenditure on healthcare costs exceeds a stipulated percentage of your capacity to pay. Now, capacity to pay can be measured in a variety of ways, but I'm not going to go into that now. Impoverishment is whether the expenditure on healthcare drives a household below the poverty line or further within the poverty line itself. And that poverty line is determined, it varies, it's determined by governments. And again, I'm not going to go into that. It's just so that you know, it's how much you spend in relation to how much you earn or can afford to spend, basically. The way that both of these are calculated generally, conventionally wouldn't consider transport costs as expenditure on healthcare. But there is growing international pressure to actually consider transport when calculating these things, which is great. Okay. So in South Africa, only 1.4% of households experience catastrophic health expenditure when seeking healthcare at the 10% threshold, which is pretty low. Looks like we're doing good. There are tax rebates for taxpayers with disabilities. There's free healthcare for people with disabilities meeting the H0 criteria in public sector. There's free healthcare at primary healthcare clinic level in the public sector. So we're doing well, but we're not. Because the inequities in access and health outcomes for people with disabilities in South Africa remain unacceptably high. And clinics and hospitals remain quiet. We don't see them. So why? So yes, it matters who delivers the healthcare, where the healthcare is delivered, how it is delivered, and what services are delivered. Yes, that matters. But the hidden stuff that make or break your service, that really determine whether the people come access your service in the first place, or whether they return repeatedly and are like remaining in care, can be as diverse as the quality of care that's offered, the cultural beliefs around the condition itself, what can cure it, etc., how much social support the person has, what the transport costs are, whether the service is available or not, and where it's available, whether there's perpetual stock out, so is the service reliable or unreliable, whether there's stigma in accessing the service in the first place, and financial autonomy or decision-making autonomy, and this is particularly relevant to children with disabilities, whether the service is acceptable, whether your healthcare professional is actually skilled enough to deal with it or culturally competent, and how coordinated your care is. If your care is all over the place, it's going to be a disaster for the people at the bottom. So again, transport, it's a major hurdle. So in the who are not affiliated to the South African Taxi Association can simply refuse to take people with disabilities, or the pickup point to get to them is also inaccessible. And that could be as short as 100 meters. But I live in an area where there's thick beach sand. I mean, I've got thick beach sand. Eastern Cape has got hills. You know, we've all got problems. The slums have got a lot of other issues. Even if the pickup point is 100 meters away, if you don't have the social support, or if you don't have the assisted device or the appropriate assisted device, you can't even get to the bush taxi. If they do take you, they often charge extra for the wheelchair and extra for the caregiver. If they don't take you, which is for many of my people with moderate and severe disabilities, then your only option is to hire a private car within your own community. And across the board, from the closest area to the hospital to the furthest away area from the hospital, this works out at around 10 times the local taxi fare. So people with disabilities who are unable to use the bush taxi network are now paying 10 times the amount of somebody who can use the bush taxi network. And yet these are common policy level phrases that I've heard at the top. But we have an excellent central specialist rehab facility in this province. Rehab is fine. If they need rehab, we can just bus them to the closest facility with rehab. The facility is quiet. We certainly do not warrant So now we have a data conundrum. The tenets of universal health coverage, access to care, financial risk protection. Okay, we know that there are multiple barriers in access that are specific to disability, but also specific to different disabilities within that group. It's not a homogeneous group. But the current analyses do not routinely measure the inequities in access to healthcare for people with disabilities. On the financial risk protection, we know that people with disabilities pay more out of pocket to access healthcare because of transport and assistance that's required, up to 10 times the amount. We also know that they have more complex health needs, requiring greater coordination of care and greater unmet health needs. But current analyses do not stratify for disability when considering financial risk protection measures. So we have a problem. People are getting lost in the analyses. So these phrases, some of them from my own staff, a long time ago, thankfully. We're short-staffed. The roster indicates area X that we should be going to do outreach on. You know what? The kids there are doing fine the last time I checked. I'm sure we can skip them today. It'll be fine. He was seated beautifully and the caregiver was so involved. That was only last month. No, it's the parent's responsibility to make sure they bring their child. We are not going to chase them. He or she, they're a defaulter. You know what? That caregiver or client never followed any of the advice we gave her at the clinic groups or during treatment. We offer a group monthly at the hospital, but they just don't come. So I'm going to talk about the health reforms that we underwent during COVID. Our slogan is never waste a good crisis. When people and staff are geared for change, immense change, like Lockdown 5 change, they're also geared for any changes that you're about to make to the staffing and to the health systems. So it's a good time to make so we made a conscious decision as a team to move all of our moderate and severe disability services to homestead level immediately from then. But that was a little easier said than done because we had all of our different service data was on different spreadsheets. So we had the wheelchair database, we had the home-based care database, we had the blind database, we had the CP database. And they were all in Excel and they didn't speak to one another. So we had to sit down and put them all together. And in doing so, we realized just how much duplication there was, just how many missed opportunities there had been, and just how many lost to complete follow-ups there were. And then we started to panic a little bit. So we cleaned up that data and we landed up with over 450 people that now required urgent and regular home visits. And then we panicked further and we realized that Excel just wasn't going to crack it. So we then had to design our own electronic system that would allow our therapists to share data between each other. Because within one patient, they may need to be seen by OT once a month. They might need to have their seating reviewed once every 3 months. They may need a chronic review by the doctor for their meds every 6 months. And all of that has to be coordinated. We obviously shifted all of our services to home. That also required integrating it with primary healthcare existing networks, so like outreach team leaders, community health workers. Otherwise, you're driving round and round in circles and not finding anyone. And also landing up trying to treat medical problems by yourself. Into our rehab service. And so we realized, especially during the lockdowns, that we absolutely needed them. We needed to pull on them because they were the eyes and ears at the community level, and they also had the networks that we didn't have. So we spent a lot of time, effort, and resources in building up our peer support network. We now have 3 parent facilitators and 4 spinal cord peer supporters. They run their own NPO, and it's fully integrated with rehab. But we also, in this lockdown, we were also raising, because there was a food security issue, we were also raising funds for food parcels because SASSA and DSD were a little bit slow to the party in rural. Yeah? So we only had a limited amount on, especially because the SASSA grants had been centralized as well. And we needed to put in a threshold for poverty, our own threshold, so that we could decide who to give these food parcels to. So that worked for COVID. And then we decided, wow, this data is actually very useful for other advocacy purposes. So looking back on our adjustments that we made, I have only focused on the CP services for this analysis. And I've taken the pre-COVID data that we had that was good enough. So that was 2018, but rehab sessions in 6 months that a 0 to 5-year-old got, a 6 to 12-year-old got, what proportion of our kids got annual wheelchair reviews in the 0 to 5s. That was 0%, literally. Once we gave you that buggy, we never saw you in that buggy again because it was kept at home. 0 to 5s came to the clinic, so they at least got some rehab sessions, but they never ever brought their buggy. And then we looked at the 2021, so post-reforms, and it was, I mean, it's mind-boggling just how much better our coverage rate is. We are using up, and it's done by an intermediate or an advanced seater. And then we were worried in 2021 that obviously we weren't going to be able to sustain it because everything had to go back to clinic, and OPD started pumping again. And I went back to my staff and I said, do we stop all these home visits? And everyone was like, no, absolutely not. The number of times I've gone to the homestead and realized that what I've been working on with this child for the last 4 years at clinic was an absolute waste of time, because now I've actually seen what the real problem is. And also just look at the data. There's no way we can stop this. Our annual indicators, and 2024 is not finished. I can't calculate it, but our 6-month review rate is at 80% now, and we've actually improved. So the factors driving this impact, big one was affordability. So mainly it was home-based service, so no more transport costs. Yay, everyone happy. Okay, but the other stuff, the more subtle stuff, was that it was a lot more acceptable. We beefed up our parent facilitator service, our parent champions. They were seeing the kids in between us. Is actually going on versus a chaotic clinic environment. The kid is tired, the kid is hungry. It's not a very private environment. It's loud, everyone's grumpy, you've got limited time. It's not a great environment to see these kids in. Accessibility, as I've said, the parent facilitator is an intermediary. She was the go-between. She's the health community interface. She's got the lived experience. She has a child with CP herself. It's integrated now within our rehab service. And obviously we had done a ton of health system strengthening, basically cleaning up our data and building a system that told us who needed to be as I said, our team was quite worried about going about what would happen now that we had to shift, now that lockdown was over, and we basically had to go back to seeing clinics and a pumping OPD. So we took that household data that we had collected during lockdown and we put it to good use. So we decided to, in our very non-health economist qualified way, try to calculate a catastrophic health expenditure for 3 different models of care. So initially we'd used 80 households. I've recently redone the same calculations using 132 households. People eating from the same pot. Because not everybody in a homestead contributes equally to the same pot, and some people actually don't contribute at all. They manage their own funding. So total grant income contributing to the same pot, number of children and number of adults eating from that same pot. The cost of a single round trip to clinic and a single round trip to hospital, in which with the assistive device, in whichever manner would be acceptable to that family. So if the taxi took them in their assistive device, fine, and they used it, then they gave us the taxi rates. If they didn't and they always had to hire a car, they gave us the hired car rates. We then looked at our own and then we looked at process indicators, which are your seating reviews and your intervention sessions per month and where they happened. Oops, sorry. Yeah, there we go. So we had to make a number of assumptions, and they are explicit assumptions, and they are there. I'm not going to go through them. It's probably only of interest if you are a health economist. But it basically says the assumptions that we've made, are they likely to overestimate or underestimate the catastrophic health expenditure? Having done the same calculations on 132 households, it actually became worse. So what proportion of the 80 homesteads would be driven into catastrophic health expenditure with the current model? Okay, so at the 10% threshold, so that is spending more than 10% of your disposable income, basically, or your capacity to pay on healthcare costs, even with our current model of a home-based service, 8% of households with a child or adult with CP would be driven into catastrophic health expenditure over 8 months in complying with rehab. If we moved all of our services to a clinic model, also, again, in the case where you needed to go to a hospital, that was kept constant. It was unavoidable. 18% of households with a child or adult with CP would have been driven into catastrophic health expenditure over 8 months in trying to meet If you consider that South Africa's catastrophic health expenditure is estimated at 1.4% at the 10% threshold, you can see now just how bad, how much more families with people with disabilities are paying in trying to get to rehab. And this is my favorite. This is the slogan of the Department of Health in KZN. It is fighting disease, fighting poverty, and giving hope. Let us fight poverty and give hope. And that was calculating this just for rehab visits. So what about the non-rehab health needs of children with CP? Also a caregiver strain. Okay, so we know this. So we went around trying to convince our multidisciplinary, our multi-professional team to come and do home visits with us, but they were a little hesitant because everyone's hesitant to shift their services to home because of the anticipated time that it will take. So rehab said, okay, cool. Please, could you guys design your own screening forms that a therapist could do with a child at home? So Dental designed their screening form. $39 children so far, children and adults. 30% had unmet medical needs. 10% haven't been for their 6-monthly chronic follow-up. Dental, 65% had never seen a dentist in their entire life. 61% needed to be seen, 30% for extraction under general anesthetic. 95% had never seen an audiologist. 17.5% required ongoing management for wax. 30% failed their first audio screening test, OAE. 17.5% had a fungal or bacterial infection, usually for the kids and adults with EDAX 4 and 5s. Dietetics, they were horrified, shame. Footprint and really good integration with primary healthcare networks and community health workers. So they were absolutely appalled. So we came back to our multi-professional team and we said, here's the data, and everyone was appalled. And now we are having discussions based on the data from the catastrophic health expenditure that my team now understands, and based on the outcome of the screening for the unmet health needs, we are now having discussions on how once don't make the patient fit the service. And this is by Maryke, because I say so, trademark. Thanks.
Maryke, thank you very much. That was a lovely talk and incredibly informative. My apologies, we unfortunately sort of missed some of your words here and there with the internet connection. But you did warn us beforehand that you're in proper rural Africa. And thank you so much for the time that you've done. And thank you for this incredible addition that you bring to our evening as well. Can I ask that if someone has specific questions, that they please can type it into the chat area, and I'll voice them. I think let's go on to our next speaker, Carla. Can I ask if you can please show your slides, and then we'll sort of, maybe we can discuss it for a few minutes at the end of our evening. Thank you very much, Maryke.
Yeah, I'll start sharing now. Thanks very much. Can everyone see?
We can see it's in the presentation mode. Can you just change it into the slide mode? Then that's perfect. Perfect. Thank you.
Okay. Thanks, Nico. Thanks, Maryke, for that. I think I'm probably going to make some links to that. And I can definitely say that even though we in the city, Maryke, we have exactly the same transport issues that you shared. And it definitely affects the services for a lot of the differently abled children that we see at our hospital. So thanks very much for Nico for inviting me to share this presentation. My objective tonight, and I hope to be able to achieve it, is just to give you a brief background and context of the social security assistance available in South Africa for disabled children. But I'd more want to engage your critical thinking around the care dependency grants for children, because I think a lot of people feel very negative towards it. I just want to advocate as to why children with disabilities need it and deserve it, and that they don't have a big part of the pie, of the social security pie at the moment. So to start off with, I just want to introduce you to the social assistance grants in South Africa. And as you know, in terms of the Constitution, every citizen, including children, have a right to healthcare, to food, to water, and especially to social security. South Africa actually, we know, has an extensive legal framework which names and protects the rights of children in general and the disabled child, and the state has a responsibility to fulfill this to the best of their ability. In South Africa, actually, we've got a fantastic legal framework that includes things like the Constitution, the National Development Plan of 2012, the White Paper on the Rights of Persons with Disabilities, and the Children's Act of 2005. And all of this creates a framework that protects children with disabilities, that should promote the care and development of disabled children, and that should help us to advocate for the realization of these rights. If we then also consider this in the context that all grants are administered by the South African Social Security Agency, and that they in turn are mandated by the South African Social Security Act of 2004 to provide this service. So I want to tell you, and perhaps many of you will know this, but we've got 7 different types of grants in South Africa. The first one I'm just going to touch briefly on all of them. The child support grant was introduced in 1998. It replaced the state maintenance grant. Presently, we've got over 30 million children who are recipients of this grant, and it pays out 530 Rand per month to a child receiving the child support grant. Next is the foster care grant. It's given for children in need of care and protection who are removed from their biological parents and placed via the Children's Court in an alternative caretaking system. We have under 300,000 in 2022 was recorded to be in the foster care system, and that grant costs us 1,180 Rand. Then, of course, we have old age pensions. That started as far back as 1928 for coloured and white elderly, and later on, I think a number of years later, for the same thing for black old people, they started getting that pension. And we've got in 2022, it was recorded that we just had about 4 million aged receiving the 2,180 Rand. Then we've got the grant in aid, and the grant in aid is an add-on to old age pensions or disability grants. It's there for people who need full-time care. It was introduced in 1996, and we've got over 300,000 recipients of this 530 Rand. Then we also have linked to that is the disability grant. That's for adults with temporary or permanent disability. There's over 1 million adults that receive this, according to SASSA in 2022, and it's also a grant of 2,180. And then the grant that's really the focus for some of this discussion from my side is the care dependency grant. This was introduced in 1996. It's for children who are disabled and in need of full-time care. The 2022 stats show that there was 157,000 children receiving it, but later in this presentation, I'll speak to the more updated stats of 2024, but it's also 2,180 Rand that's received. The last grant was introduced during our time of crisis, when a COVID hit in 2020, unemployed people with an income less than 624 Rand, which is close to the poverty line, you are allowed to apply for what's commonly called the COVID grant, and that's to the value of 350 Rand. And we've got, in 2022, we had 7.3 recipients of this grant, and that has increased by at least 2.5 million since. So I want to also just look at the context of the population, and you'll soon realize why I'm sketching this picture. So in South Africa, we've got just under 61 million people. We've got a population growth rate of 1%. We've got a mean age of 27.6 and the highest unemployment rate in our youth workforce. And presently, 42%, according to SASSA and according to the government, 42% of our population are recipients of SASSA grants. So Cyril Ramaphosa, it's ironic that our presentation was leading up to this voting day, because it was in the lead up to this voting day that Cyril Ramaphosa very proudly was pronouncing that there are 28 million South Africans who are SASSA grant recipients. And I can tell you that 10 million, no longer 7.3 million, I think is the number I said before, but 10 million people are now receiving the 350 Rand grant per month since COVID in 2020. So in 2022, SASSA tells me that they spent 232 billion rand on grants to 26 million people. That was 11% of our GDP. But this has since increased because now President Ramaphosa says we are providing 28 million grants. So definitely there's a bigger piece of the GDP cake that has been taken by grants. Unfortunately, for the last year, for last year, we had 7.4 million taxpayers. And if I'm correct in terms of what the finance world is telling us, there's only 7.1 million registered taxpayers in South Africa. That means 4 times as many grant recipients. There are 4 times as many grant recipients as there are taxpayers. So in South Africa, we have 20 million children, and Stats South Africa has found a 7.5% prevalence rate of disability in South Africa. Remember, I told you that 13 million children receive the child support grant every month, and of that 13 million, 7 million live below the food poverty line. The child support grant is presently 530 rand per month, and recently there's been a top-up grant for children who are orphans, and there's an additional 240 rand that's been added to their pot. However, the children receiving the 530, they are way under the 663 rand that is regarded as the food, where the food poverty line stands. And this stats and numbers have come from a review done by the Children's Institute, and they were asked to do this review by the Minister of Social Development in 2022. So this is just a visual for you to be able to see how the grant system has actually increased significantly over the last 30 years since we became a democracy in 1994. And the most significant change has been the increased number of children who are accessing the 530 rand grant, but also the most significant in the recent number of years since COVID is the number of adults that are now receiving state assistance because of the high unemployment and poverty rates in our country. So how many disabled children receive the care dependency grant? According to Stats South Africa, and according to the household survey that they've done, they say that there's 720,000 children with reported serious disability. I suspect it's a lot higher than that because in this audit that they did, they looked at they excluded the age group as far as I could find of 0 to 4.9 age group, but they have found that the highest percentage of children with serious disability is in the 5 to 9 age group. So SASSA has given me this document where this is stats for March 2024, and I want to hone in on the care dependency grant. So the care dependency grant is the total number of recipients. Remember, I told you early on that the number of recipients has increased in the last year. So it has now increased to 165,764 children in South Africa receive the care dependency grant. And if we look at this cutout, you can see that the KwaZulu-Natal province actually receives the highest number of care dependency grants of just under 42,000. They're followed by the Eastern Cape and Gauteng with just under 25,000. Then it is the Limpopo province of just 18.5. Then it's the Western Cape of 18,000, and the rest of the provinces are anywhere between 6,000 and 12,000, but it amounts to 165,000. Now, if you recall, if the stats is true that there are 720,000 severely disabled children, then SASSA is only paying grants to almost 166,000 of those children. What's happened to the other children? I don't know. So what slice of the SASSA cake, grant cake, do disabled children actually receive? Disabled children are receiving the CDG monthly amounts to 0.52% of the total number of SASSA grant recipients. So disabled children are really being shortchanged. And I agree that we don't realize the actual costs for caring for a child with any form of disability. I've listed some of these same areas that's been mentioned by the speaker before me. I mean, we know that special school fees and transport transport fees to and from schools. While the school fees are sometimes low, transport fees from our special schools are high, and children cannot be excluded from that. Parents do not have the ability or the means to provide transport for these children to and from school. The aftercare fees, if you have a child that's not disabled, think about all the working parents in this group and how many of you pay astronomical fees for aftercare for your children. So how about having a child in the wheelchair coming home from Temberley to school and now needs aftercare because that child arrives home at 4 o'clock and the mother works as a domestic worker in Sea Point and she arrives home at 7 o'clock. Then there's medical costs. And yes, it's true that the under sixes receive free treatment. They've registered as an H0, but there are many low to middle income families who don't receive free medical care. Nutritional costs. There's structural costs. Many children live in informal housing. They need ramps, but they don't have ramps. They need wheelchairs, but they can't use the wheelchair up until their front door. They need wider doorways, but it cannot be built because the shack is already in existence. They need floors, but the parent cannot afford to put on a floor, so they just live on a carpet on top of sand. Many parents need many children need special apparatus, which ranges from the list that I've put there, but it goes right down to the basic toileting aids. I mean, where does a child do a bowel washout if all you use is a bucket? You know, when the family gets up in the morning, they pee in a bucket. What do you do to do a bowel washout and to do intermittent 3-hourly catheterization with your child with spina bifida? So you need special aids within your home, and most people cannot afford it. Then there's a cost that many of us don't think about, the cost for the mental health of this family, the cost of respite care for that child while the family takes a break. So if we consider the care dependency grant being 2,180 Rand per month, the basic expenses of any child, let alone a child that's disabled and has special needs, cannot be covered by the care dependency grant. And by no means am I trying to absolve the parent or the caretaker of their responsibility towards the child. But I think we need to consider this amount of money as being completely unrealistic to offering a fair resource to children who are severely disabled. So we all want to change the world, and we want to do lots of things, and we want to realize the rights of the disabled child. And I want to challenge you that you've got a means to do this. And your means to do this is this. I want to say that you need to continue advocating for the daily needs of the disabled child. Just like we heard before, the daily needs possibly just involves the transport. You know, people living in the Western Cape, do you know how much it costs for a mother to bring her child from Atlantis to Red Cross Children's Hospital for an appointment? It costs in excess of 160 Rand to do that trip to and from Red Cross Children's Hospital. So if you consider taking 200 Rand out of 2,180 Rand, and perhaps you have not one appointment, but 2 appointments at a tertiary facility in Cape Town, it can really take out a third of your care dependency grant. The next thing is I want to advocate for early assessment of the child and early access to care dependency grants. This needs to be prioritized because even at Red Cross Children's Hospital, we are seeing a lot of children who are diagnosed with chronic illnesses and disabilities that by the age of 5, by the age of 10, have still not been assessed for access to a care dependency grant. Healthcare professionals need to take the time to understand and assess if this child's medical condition qualifies them for a care dependency grant. They just need a fair chance to be assessed and to see if they qualify. Families can, in actual fact, earn up to 500,000 Rand and qualify for the care dependency grant. That's the means test that SASSA conducts, but SASSA tells me it's up to 500,000 Rand. And so lower to middle income families are able to qualify for care dependency grants. We get an enormous amount of children, especially of children on the autistic spectrum, that's coming in from the private hospitals, where parents are realizing, oh my gosh, I can actually qualify for the care dependency grant. Then there's been two significant changes in 2022 to the Social Security Act of 2014. The first one, and I'm hoping that all of you in this audience knows this, that any healthcare professional registered with the HPCSA can complete and sign off the care dependency grant. It's not just doctors, it's physios, it's OTs, it's audiologists, it's speech therapists, it's psychologists that can sign off a care dependency grant. And this is fantastic for the rural areas where we often have a low number of doctors visiting clinics maybe twice a month. But what you do have is you do have an OT or a physio more available within the rural area. The second big change that came about in 2022 has been that the care dependency grant can now be authorized for a shorter period of time, 1 year, 2 year, 3 year, 5 years, and with a review. So what this means is a child that needs a rehabilitation period can be given a care dependency grant for that period, and then you can ask for a review. It means that it will work in the advantage in terms of that we won't just drain the system where children endlessly end up on a care dependency grant from 0 to 18 years and no one reviews it. We can now responsibly deal with the money allocated to this grant, where we can then review and see if children need to qualify for it for the entire childhood period or just for a portion thereof. And lastly, I just want to remind you of the eligibility criteria for the care dependency grant, that it's paid to a parent or primary caretaker or foster parent looking after a child of 0 to 18 years, requiring or receiving permanent care, or it's not and, it's or support services due to physical or mental disability. As long as that child is not found in a state institution, state-run or funded institution, that child can qualify. And the last thing that I want to say that you can do that we can possibly do as a group to improve the rights of the child is to also look at tax reform, especially for the low, middle, and even the upper income earners, as to how can we get greater tax reform. And I know that the next speaker could possibly touch on that topic. So from my side, I just want to say, as you can hear, I'm very passionate and a fierce advocate for the rights of the disabled child, because I just feel we need to help them to gain fair access to the financial social security that's available to them in South Africa. And you, yes, everyone who is a healthcare practitioner that's registered with the HPCSA, you have the ability to make the difference in the life of this disabled child. You need to take the extra time that it may take out of your assessment with this child to see if they qualify. 3 weeks ago, I had some training at Red Cross Children's Hospital on the care dependency grant, and asked our own staff to attend. The turnout wasn't so great, and I can guarantee you that on Thursday morning, I'm going to have more parents coming to me to say, does my child qualify? Why does my child not qualify? And I'm begging you, make the time within your practice to assess and to see and to treat the disabled child fairly, to see if they actually qualify. Thanks very much.
Well, thank you for a wonderful talk as always. It's an incredible topic, and it always makes us think. And it's always such a difficult topic to think about, because I mean, on the other side of this whole thing, in that it's one of the ethical questions that often comes up in our practice every day, in terms of how hard do you fight for a child's life,
yeah.
in terms of increasing the burden on the family. And one of the most difficult thing for any person is to not do something. It's much easier to operate or to intervene or to do something. It's very, very difficult to stand back and say that this situation is not salvageable, and if the child does survive this horrendous vehicle accident or brain injury, the outcome for the family might be dismal in the long term. It's interesting what you mentioned, the 160 Rand from Atlantis. It's expensive. And Maryke in the chat has added that for her, it costs them about 1,200 Rand for a single round trip to the hospital with a hired car for families to get to them. And it's just immense, the numbers that we talk about. Adelleen, may I ask if you can share your talk? And then I think we'll group together with questions at the end. please forgive us. We'll run a little bit over time, but I don't think we need to be too rushed. It's such an important recording that I'd rather like us to continue calmly with it. Thanks very much, Adelleen. Welcome.
Okay. Hi, hello. Okay, let me just see if I can share my screen quickly. Right. Cool. Okay. So thank you, everybody. Thank you for having me. As you know, my name is Adelleen Gouws. I'm a tax specialist, and I specializes specifically in disability tax. We've got a whole portfolio of clients that we assist on an annual basis to claim back tax in relation to their dependents or themselves that might have a disability. So in a nutshell, how this works is, if you as a taxpayer has a dependent that has a disability or qualifies in terms of the SARS criteria, remember this is different from the Department of Labor or SASA criteria. This is the SARS criteria. And if you qualify, SARS views your entire tax return or the medical aid portion of your tax return through a different lens. I just wanted to make sure, do you see my slides at the moment?
Yes,
Yes.
thank you. We can see
Okay,
it.
perfect. Okay. So, yes, so there's a specific formula that is applied to your medical aid premiums, your medical expenses for all individuals. But if you have a dependent, or if you yourself qualifies as a disabled person, the formula is different. And that has a very big impact on your tax calculation. So you can pay a lot less tax if you have a dependent with a disability. So let's have a look at the criteria. Number one is there's various categories. I mean, disability can have a broad range. It can be something physical, sensory, communication, or even neurodiversity, like things like autism spectrum disorder, or I know ADHD and things like, what is the word, dyslexia, is sort of gray areas, and SARS is quite strict with that. But from experience, I know that those things normally run along with comorbidities, call it that, like severe anxiety, depression, things like that. So on the mental side, even if the main diagnosis is ADHD or dyslexia, the secondary diagnosis of depression or anxiety could be one of the qualifying criteria that could get the dependent qualified as disabled in terms of the SARS criteria. Secondly, the disability or the impairment has to have a significant effect on someone's daily life. So if you have a child that is on the autism spectrum disorder, but they can sort of function normally in a normal school environment, they would probably not qualify. But again, if they need to attend a special school or need some kind of special intervention in order for them to attend a special school, then that could be then they could qualify. Thirdly, it has to be a long-term condition, so it has to last or be likely to last for at least a consecutive 12-month period. And lastly, the diagnosis has to be confirmed by a relevant medical practitioner. So if it's a physical disability, it would probably be done by a orthopedic surgeon, or if it's a mental thing or autism spectrum disorder, it would have to be qualified by a neurologist or a pediatrician or a occupational therapist, someone like that. That is done by means of a SARS form that has to be completed. It's called the ITRDD form, as noted on my slides. It has to be completed by the taxpayer and also the doctor that made the diagnosis. Okay, the relevant medical practitioner. Right. So once a taxpayer qualifies as someone with a disability or someone with a dependent with a disability, what can you actually claim? So the way I see it is the formula that is applied to calculate the tax savings or the tax benefit consists of three components or three buckets. You've got your medical aid premiums, you've got your medical expenses, and you've got non-medical expenses. The first bucket, the medical aid premiums, is for the entire family. So all the medical aid premiums that a tax practitioner pays for all their dependents. So if you have a membership with Discovery and it's you, your spouse, and your 3 children, all of those premiums are included in that component of the formula. Also, if a taxpayer pays the medical aid premiums of another individual, for instance, their parents or a brother or a sister that cannot afford the premiums, those medical aid premiums can also be included on their tax return and in this calculation. Right. Secondly, all medical expenses that are not covered by the medical aid, that is paid for by the taxpayer, is included in this formula. So there's normally when we submit the return, there's 2 components on your medical aid tax certificate. Everything that you've submitted to the medical aid that they've rejected because you run out of funds or that particular benefit isn't covered, it's listed on the tax certificate. But the second component is stuff that you've paid for cash that you've never even submitted to the medical aid. Stuff that you bought at the pharmacy or prescription medication. All of that is included in the second bucket, in the second component of the formula. Again, that is for the entire family. It's not just for the individual with a diagnosis. So if dad went to the physio or a sibling had to get braces and went to the dentist, all of those expenses that were not covered by the medical aid is included in this section. Then lastly, you get the component that deals specifically with the dependent with a diagnosis and that particular diagnosis. And those expenses doesn't have to be medical in nature. That is where stuff like Maryke mentioned, like the travel expenses to get to the specialist for a consultation. That is not a medical expense, but it's related to the individual with a diagnosis and it's related to that particular diagnosis. Those travel expenses can be included in that bucket or that portion of that component of the calculation. Another thing that plays a big role is special school fees. So you can claim the difference between your special needs schools fees and what you would have paid if your child attended a normal state school. Another thing is if you had to get a facilitator or extra tutoring or aftercare fees, things like that. Or if you had to buy nappies for someone that still has not been potty trained at a high age. Those kind of expenses all fall in that category of non-medical expenses that the taxpayer incurred. That is related to the condition or the diagnosis and the individual with that particular diagnosis. So if you have a look, let's just do a quick example. I had something here on my website. I've got a very nice calculator that you can play around with and add in your own numbers based on your family or your patient's scenarios, whatever the case may be. But for simplicity's sake, we just took a quick example of a family of 4 individuals, for instance, that are on a coastal core plan with Discovery. Let's say I looked up the premium on their website. It's 6,970 Rand. 6,907 Rand per month is their medical aid premiums. That's the first section of the formula. Secondly, additional medical expenses that they had to pay for cash. That was not covered by the medical aid. Let's say, for instance, that is 3,000 Rand a month. And let's say, for instance, this family, the child is in a special school, which is 2,000 Rand a month, more expensive than the closest state school fee. If you put all of this into the calculator, this family could save almost 33,000 Rand per year in taxes. Okay, so it's quite a considerable amount. It's not a couple of thousand Rand here or there. Okay, it could add up to quite a considerable amount. One thing I must mention though is that this is not a grant that Carla discussed. It's not a social grant. It is a tax rebate. So this amount that the family could get back in taxes, the 33,000 Rand, is limited to the actual amount of tax that the taxpayer have paid during the year, be it via provisional tax or the monthly pay as you earn that's deducted from their salary. So if this family only paid 20,000 Rand worth in taxes, they cannot get back the 33,000. They can only get back the 20,000. But if they paid more, obviously they can get the full 33,000 Rand back. So that's quite a considerable amount that they could get back. The process, though, is not as easy and as simple. Even though the formula in calculating the benefit is simple, it is a tricky process and it's very frustrating. I must be honest with you. We've dealt with cases that have been dragging on for almost a year now with SARS. It's back and forth, it's disputes, it's appeals. So that's where it really becomes beneficial for taxpayers to make use of a tax practitioner or someone that actually specializes in this type of service, because we know how to deal with SARS. We know what to claim. We know how to claim it. We know how to present the claim to SARS, because the burden of proof is very high. As you can see, I mean, if a taxpayer can get 30,000 Rand back, it's quite a big amount. And in the past year alone, our tax practice itself generated about 3 million Rand worth of refunds to our clients. So SARS is not just going to hand out the money. They're going to scrutinize each and every amount that's being claimed. So we need to supply supporting documents. We need to supply proof of payment. Everything has to be cross-referenced. So it's a tedious process. It's a frustrating process. And it's a long process in most cases. So for the normal guy on the street, it's very frustrating. And I would strongly recommend just to get someone to take care of that on the taxpayer's behalf, because if you have a child with a disability, you've got enough to deal with already as it is. You don't want to struggle with SARS on top of everything. Right. On top of all this, there's even more good news. You can actually triple your refund if it's the first time that you're claiming your tax return, claiming the disability tax. The tax law makes provision for taxpayers to go back and reopen the last 3 years' tax returns if the grounds are sufficient. Now, in a case of someone that has a disabled dependent and they didn't know about this benefit, they've never claimed it before, we can actually motivate the case and state the case to SARS that this individual is entitled to go back and reopen the last 3 years' tax returns so that they can claim those benefits from SARS. And that family that was going to get 33,000 Rand will now get an extra 99,000 Rand. So it adds up to about 130,000 Rand that they can get back in year one because they're allowed to claim backdated. That process is even more technical and it's a lot more hoops that we need to jump through. So definitely I would recommend making use of a tax practitioner to assist you with that. But it is definitely possible. Of all the tax returns we've submitted in the last year, we've had about a 99% success ratio. We haven't had one client where the claim has been refused altogether. Maybe 1 or 2 items were excluded from the claim, but in all, we've been very, very successful with that. So it definitely is worthwhile to make use of a tax practitioner in that regard. So that is when you look at the short-term effect or the short-term implications of having a child with a disability. You need to look after yourself here and now. How do you sort out your finances? How do you make provision for the expenses that you need to incur now? But something I feel even more strongly about, and that's even more important, is the long-term view that you need to take. I mean, life does hit you with curveballs. It's unavoidable. Things happen and bad things happen, and you need to plan for that. Yes, from day to day, you need to survive, and saving on your tax will help you with that. But looking forward, it is really, really important to make provision for these things. what if you're not there? You need to look after your child. If a child is severely disabled and they can't look after themselves, you need to make provision for that. So first of all, retirement planning. A day will come when you cannot work anymore. So you need to provide for yourself to survive during that time, and also be able to provide for your dependent child during that time where you're no longer earning an income. So that's a very important factor you need to consider. Secondly, life insurance. I know it's a very morbid way of seeing things, but eventually all of us will die. And you need to ask yourself, what will happen to my family when I'm no longer here? What will happen to this dependent when I'm no longer here? Is my life insurance to such an extent that it will provide for them after I'm gone? Another more short-term kind of factor that you need to take into account is your medical aid sufficient? Is your gap cover sufficient? That'll help you cover all these extra expenses that the medical aid doesn't cover. Instead of getting a third of that back in tax, maybe you could get gap cover and get the full amount back. So it's all important things to consider. Something else you need to consider is, do you need to set up a special trust that will look after the well-being of your child once you are no longer there? You can make all these funds available, but at the end of the day, if it's not in a protected vehicle like a special trust, do you know that the child that actually needs the financial benefit will actually get it? So those vehicles are very important to set up. Second to last is your estate planning. It's all to do with your everything that you've gathered throughout your lifetime to provide for your family or your dependents when you're not there. Is it efficient? Is it done in the most tax efficient way? The big question you need to ask yourself is, what will happen when I'm no longer here? And yeah, that's the most important thing to consider. And then lastly, your will and guardianship, also important. If a dependent's disability is to such an extent that an executor would need to be appointed over them, over their finances, or a guardian, you need to think about these things now. Make sure that everything is in place, because one day when you fall away, it'll be traumatic enough for your family and the people left behind. So it's best to ask these difficult questions now, make sure that everything is in place, and it'll just take out a lot of uncertainty and a lot of stress for the family that's left behind. Now, my practice specializes in the tax side of things. We collaborate with professionals that deals with all the financial planning side of things. So all of these things I've mentioned in my last slide. I'm teaming up with a bunch of professionals that can really, really assist with this and knows exactly how all of this works, how it falls into place, how it ties up with all the tax laws. So yeah, that's something that you definitely need to consider, and that's actually more important than looking at your taxes day to day. That is important for now, but it will have a much bigger impact if you look after your family once you're no longer there. So basically, that's all the things I can mention for you now. In a nutshell, what we do, I've tried to keep it short and sweet because I know we're a bit tight for time. But thank you for having me, and yeah, thank you very much.
Adelleen, thank you so much for your time. That was a wonderful talk, and you absolutely the perfect person that we needed for this webinar. Thank you very much for being willing to add. I must say, I never knew about the tax option to match the discrepancy between your child's special needs school fees or the what's the liaison that they need to look after them, that you can actually claim for that difference as well. That's fascinating. May I ask you? Sorry, please.
something else that Maryke mentioned is the traveling expenses. I mean, I didn't realize that it was that high. The general rule that we apply is if the special needs school is more than 10 kilometers from your home, a larger than 10 kilometers radius from your home, you can also include those excess kilometers at the AA rate, which is, if I remember correctly, R4.18 per kilometer. So if you calculate that quickly, it's R4. Let's say you're 15 kilometers from your school. So it's an extra 5 kilometers in the morning and back. So it's 10 kilometers in the morning, 10 kilometers in the afternoon. That's 20 per day. Average school year is 200 school days times R4.18. And you include that in your claim and you get a third of that back. It's a couple of £1,000 just for taking your kid to school. So there's a lot of these little things that people forget. Renovate or modifications to your house. Yeah, lots of things. I didn't go into the detail, I'm sorry. It's just time constraint, but there's a lot of things that people forget or don't know that they can claim.
Absolutely. I think we can definitely spend more time with that with a webinar at another time again. Can I ask you, Maryke also asked here, she says that about the travel expenses, but what would you suggest to families in the rural areas where they have to then use an informal mode of traffic and they don't have a receipt for that 1,000 Rand that they had to pay their friend or the neighborhood disabled person's bakkie that as we know it works in these places. Is there any other way in an informal setting that you can use to motivate with anything with SARS?
I must be honest with you, I haven't dealt with that yet. I know, but Uber is not an informal vehicle that you use, an informal platform. And you get your invoices there. The problem is SARS wants to see the invoice and the proof of payment.
Yeah.
And I don't know how to get by that. I mean, if you say to SARS, this person paid cash 3,000 Rand for travel through the year, I don't know. We will definitely submit it. They might throw it out, and then we don't have any way of proving it. Yeah. But we can include it, and they might just accept it. I can't guarantee if they would accept it. But there's no way of proving it. There's no way of proving it, unfortunately.
I wonder if these families should actually buy at like a local stationery vendor or someone, buy one of those little receipt books and force the guy to write a little receipt and to sign it. Would that be more formal? Would SARS accept something like that?
Technology is even your lower income people are so technologically advanced, right? I can almost imagine a taxi driver having a Yoko machine where you can tap. I don't know. So if you can have that, at least it's something from your bank account. Most people have cell phones. Even people that use taxis have cell phones. Yeah. And if you can tap on a Yoko machine, I don't know. I'm trying to think now. A receipt from a taxi driver might work. We can definitely try and use that.
Yeah. Yeah, no, thank you. That's something very interesting that Maryke will definitely help you think of ways to do that. Someone also asked, Carla, Sarah Lang asked where they can find information that states that the healthcare practitioner other than doctors are able to sign the SASSA forms. And I see that you mentioned to her that they should contact their local SASSA disability manager. And that's pretty hot off the press information. So there will probably be formal white papers on that soon.
Okay, so Nico, I can definitely share that with everyone in the group, because I recently had SASSA do training with us, so they've sent it all to me. So it's been in existence since 2022. The difference is that the Department of Health has dealt with it very differently at different healthcare facilities. And so I'll also share that circular that we received, and so everyone can benefit from that. But it's been implemented, and it's not under discussion. It has been implemented, but I think at many facilities it's dependent on the resources that you have available, the capacity of your team to be able to offer that. But I'll gladly share it with Sarah and anyone else in the team.
Thank you. A common question that we often get in the clinic is, can we fill a care dependency grant application for a child based in another province or in another region of our province? Or is it better that it gets done by a local person within the municipality where they reside?
Yeah, it is generally better, but I think the difference is that you may not find the equivalent of the specialist within that province or close to the area where the child is resident. And so I can tell you in terms of the relationship that we've got with SASSA Western Cape, we've got a very good relationship with them. And so if it is filled in for a lot of the children that come from the different provinces, and your team fills, or any team fills it in, you just deliver it to my department, and we will engage with our local SASSA office, and they will send it on to the SASSA office in the different province. So definitely it can be completed.
Thank you, Carla. And then Sarah Lang also asked, Katlego Modimakwane asks, can we apply for a same child with both a disability grant and the care dependency grant? Or is it choose the one, and which one does SASSA then choose? The biggest paying one, or how does that decision work?
So if I heard you correctly, I mean, I can tell you that the disability grant is for 18 and above. The care dependency grant is for 18 and below. But the grant in aid, which is an additional 530 Rand, can be paid to recipients only of disability grants or the grant for the aged. So you cannot get both the care dependency grant and the grant in aid, but you can get a care dependency grant and a foster care grant. So if you are a foster parent and you are a foster parent to a disabled child, you can then get both the foster care grant of just over 1,000 Rand as well as the care dependency grant of 2,180. Okay. So there are some combinations that are allowed.
Yes. Yeah. And if I have 5 children with spina bifida, yes, heaven forbid, but say now that does happen, am I then can I then have 5 care dependency grants?
Yeah, so Nico, heaven forbid, but we do have, unfortunately, the George area is one of the areas that we have families with multiple, well, that have, at least I know of one family that has 3 children with spina bifida in George, and definitely they can qualify for all 3. Yeah.
Thank you. Thank you very much. I just want to, I think let's just look at 2 more questions and then we can end off here. I think this is going to be one of those talks on the webinars on the website that will have a very long shelf life and will definitely be a good reason for people to join SA-ChiLD so that you can have access to this webinar in future again. Oh, sorry, I now listened so nicely to your answers that I forgot to keep up with the talk and with the questions. Oh, it's people that just specifically replied to ask you for that information about the I suppose the information from the SASSA forms that you can fill it. There was questions on the website beforehand about which form to fill in. I think, Adelleen, you did address that, which is the SARS form that needs to be filled in. And I think it's fantastic that you thought further, you thought about sort of the bigger picture as well. And it's not just about today, it's about who's going to look after your child, or specifically a child with a disability once we know we're not here anymore. And I think that's a fantastic slide to include, that we always know we have to think about bigger things than just the local or the current time. I think on that note, I think let's call it the evening there. I'd like to, on behalf of the SA-ChiLD Society, thank all of you, specifically our three guest speakers, Carla, Adelleen, and Maryke. I think this was a fantastic match made in heaven tonight, and you guys brought incredible perspective to the finances of disability. I think we looked after both edges or both sides of the spectrum, those who do have a big enough income that they are tax liable, and that people can look after their family with disabilities. Having a disabled family member is expensive. It doesn't matter whether you're rich or poor. It is very, very expensive, and it's wonderful how we could do a well-rounded approach like that to look at at both sides of the spectrum. And then, Carla, thank you for helping us just clarify. That's a lovely slide. I took a picture, and I think we're gonna save a lot of people walking to and fro from your offices, just with that slide of looking at what are the 5 different grants that is available. I think it's very clear that children can get the care dependency grant only until they're 18. Thereafter, it needs to be the other grants, and then granted aid can then be on top of that if they are over that 18 year curve. But thank you very much for everyone's time and enthusiasm. Please, may I remind you, go visit the SA-ChiLD website, and please join if you're not already a member. And to our speakers, once again, thank you for your time. Good evening, have a good night, and please apologize to your family and children for getting to bed so late tonight. We really appreciate all your kindness. Have a great evening, and we'll be sending emails out soon for the next webinar in the next month. Thank you very much, everyone, and thanks for Tommy for helping us. Bye-bye.
Thank you.